I just wanted to, we have a guest speaker today. Dr. Kalia has helped us arrange to bring in. Ben Stecher is one of the patients in the movement disorder clinic, but has become a very big advocate for research in the field of neurodegeneration, and is also on the patient advisory committee for the movement disorders clinic upstairs. And he has graciously offered to give us his insight into the disease and also kind of the research around that. So anyways, thanks so much for coming.
Okay, thank you everybody for having me here today. I wanted to kind of get a quick sense before I begin though of who I'm speaking to. I know most of you are residents here, but I don't even know exactly what that means. I've never been through this kind of system before. So can I get a quick sense, I guess, of how many people here have expertise or focus on Parkinson's? Nobody, okay.
They're all going through to become general neurologists or general pediatric neurologists. And to be a general neurologist, you have to know about Parkinson's and all the Parkinsonian stuff, but you do not have to be an expert in it.
Okay.
That's a fellowship, and then you become, like Dr. Kalia, an expert in the field. But this is the intermediate stage.
And is anyone taking a more research focus approach? I mean, is anyone thinking about going into research, into the basic sciences, or?
So more gait disorders.
Okay. Interesting.
And maybe amongst them, there may end up being people who are going to go into movement disorders.
Yes.
Right?
Yes. I'm sure there are.
Maybe I wanted to go.
Well, maybe I'll help convince
or maybe
you
you'll switch them
or
around.
dissuade you. We'll see what happens. So I'm kind of at the end of a long series of travels that I've been on, at least recently. And one thing I like to do in these presentations is to make them as visual as possible. Not only in the images that I put up on the screen, but in what you see in me in particular. So I was diagnosed myself about 6 years ago, and one of the kind of cardinal symptoms of Parkinson, or cardinal signs, or cardinal things that patients deal with are these fluctuating on-off symptoms. And throughout this presentation, so right now I'm on, so I'm a little dyskinetic at the moment, but hopefully that will pass pretty soon, and you'll see me transition to off, and then if it does happen, I'll take my medication, and probably in half an hour or so afterwards, you'll see me go back on, although I don't know if we'll have time to kind of go through the whole ride. But just to give some context to what you're seeing in me as this presentation goes along. So another question that I'm going to have for you throughout this presentation, and something that I'd like your help with, is I'm going to be kind of laying out what I've seen as some of the big problems in Parkinson's research and in how we treat this disease as well. And I'm wondering how much of what I say actually applies to other disease areas as well. It's something that I've often wondered about, and something that I'm becoming a little bit more of a vocal advocate about as well, is trying to break down some of the barriers that exist between these disease areas. And I wonder how accurate that notion actually is, how much we can actually apply from the lessons learned in Parkinson's disease to other disease areas. So if you want to chime in at any point, if you have any comments that you want to say in particular, please feel free. And what I'd really love afterwards is if you have any feedback for me, please feel free to send it. I'll give you my email and contact information towards the end, so you'll be able to reach out to me and really help me come to a better understanding of whether or not some of the things I say do apply across disease areas. So no relevant disclosures to say at this point. So the journey that I've been on, it started for me in Tikal, Guatemala. I was about 25, 26 years old at the time, with a slight tremor in my right foot. I didn't think anything of it at the time. Over time, I came to be diagnosed here in Toronto at the age of 29, although at the time I was living and working in China. And one of the biggest problems that a lot of patients face, especially early on as we come to understand this disease, is that we don't have the tools and the information needed to really make sense of what's happening to us. And as a result, patients often fall down a lot of weird, strange rabbit holes. And the internet, for all the glory it does, doesn't always help. So this is one of those rabbit holes that I fell down. This was back in China. A friend of mine took me to see a doctor of traditional Chinese medicine. And what she's doing in this picture is she's taping some kind of seed to my ear. Then she gave me that bracelet to wear, and she told me to walk west for 1 hour every single day. And eventually, somehow, I'd be cured. No. To her credit, I didn't run the experiment, so I don't know what would have happened. But this is just one example. There's countless other examples that, not a week goes by that I don't have some family member or some friend reaching out to me saying, oh, I heard about some crazy supplement or some crazy new therapy in some part of the world that supposedly does wonders. So I realized early on that I needed to overcome this problem, that this was going to be kind of a big challenge for me to overcome. So what I did is I started traveling. I traveled to every research center I could get my hands on, essentially, and asked the brightest minds that I could come across what was the latest that was happening in this disease, and more importantly for me, how could I help move things forward. I also soon became acutely aware that there are some problems in how we deal with this disease, how we research it, and how we treat it, and how we actually try to make things, progress things forward. So I've been trying to kind of diagnose the field and try to assess what are some of the things that can be done about it. And that's going to be the focus of my talk today. So the first part of it is just going to be almost a list of complaints in some sense as to some of the things that are wrong. And then towards the end, I'll get into some things that I think need to be done to push things forward. But I made my career in education beforehand. Education's always been a very important part of my life. Well, after I graduated, it became a very important part of my life. And this is what I've tried to do. This is kind of how I've tried to give back to the community as well. I noticed early on that there was a dearth of good information out there. So I did what any good millennial would do, and I started a website where I started to interview some of the world's leading minds in this subject. And here are just some of those faces that have really helped shape my understanding of this disease. Now, it's a smorgasbord of patients and doctors and scientists and some CEOs of companies and some Nobel Prize winners thrown in between as well. But these are the people that have really helped me understand what's going on in my brain and have also helped form my opinion of the field and of some of the things that need to be done. But, kind of to jump right to the conclusion, I've noticed that there's kind of an overarching problem, or an overarching kind of inconvenient truth that I stumbled across along the way. And that is simply that the rate at which science is progressing is slower than the rate at which the neurons in my brain are dying. It's a hard truth that at some point I had to kind of accept and deal with, but it does seem to be very much true that there's a lot of things that are impeding our ability to properly understand and treat this disease. And it's something that I've just kind of had to stomach along the way. And I'm going to try and lay out for you why I came to these conclusions as we go through. So the first reason for that is we simply have a hard time understanding what this disease is. We have some kind of loose ideas about what it might be. These accumulations of proteins are kind of our best guess at this point. But they seem to be just that, a best guess. We don't have any definitive way of saying what this disease is. And I found this to be true across diseases as well. I don't know if anybody saw, but the Journal of Parkinson's in November last year, the Journal of Alzheimer's in November last year, they put out a prize from some wealthy donor in Tennessee or something like that, offering $2 million for a concise definition of Alzheimer's disease. It's still an ongoing prize, so you can feel free to jump into that if you want. It's still an ongoing competition, so feel free to jump into that if you want. But I'd love somebody to do that in Parkinson's as well. It seems we haven't properly defined what we're talking about yet. And one kind of quote that I think sums up my skepticism as well of our current understanding of this disease is here. This is something that I've actually tried to do of late, is try to define it for myself based on everything I've learned. And I'll be happy to share that with you guys later on. But it is something I think that we should be constantly thinking about going forward, is how do we actually define what it is that we're working on, what these diseases really are. The next problem I kind of encountered is that we have a poor understanding of biology itself. We don't really know fundamentally what's actually happening on the cellular level in a healthy human being to begin with. There's one question in particular that I love to ask a lot of the basic scientists that I've come to know along the way, and that is, if kind of humanity's pursuit of our understanding of biology is a 100-yard dash, how far have we come on this race? And there's one person whose answer I really liked. His name is Dario Alessi. He's one of the foremost biochemists in the field. This is what he had to say in response to that question. Now I've gone and spoken to a lot of different companies and biotech institutions and academic centers along the way, and I've come to kind of see that, especially the bolded term there, shortcuts, is very much true. A lot of these attempts, a lot of these drugs that are being pushed through the pipeline, no one can really definitively say, with very much confidence anyway, why they think it'll work. A lot of them just kind of have, there's one very prominent guy whose name I won't mention, but he told me essentially that the reason why he pushed forward this molecule in particular is because he likes to take a glasses half full approach to life. Now, while that sounds great, that doesn't instill a lot of optimism in me for the potential benefits of this molecule that he's trying out in thousands of people around the world now. Another kind of fundamental problem that I kind of came to learn about as I learned a little bit more about how science works and how research works is just that we can only go after one target at a time. And this is kind of a principle of science itself these days, is that we isolate a single variable and we tweak it up or down to see what its effects will be. Now the problem with that is I think that there's far more than one kind of variable going wrong in me at any given time. And just tweaking one variable up or down, I think, is going to be insufficient to actually dealing with these problems holistically. And just a quote from John Hardy that I think sums that up pretty well. And by the way, all of these quotes come directly from my website, so if you want to see the full interview, feel free to go on it. It's called tomorrowedition.com, and I'll send you you'll see the link to it later on. Another kind of fundamental problem is where we've looked to try to find the answers to these diseases, or to try to find the causes of these diseases. One in particular comes from the GWAS studies, the GenomeWide association studies that are being done. Almost all of them just look for hits that correlate with onset of the disease. It's kind of a binary, did upregulation of this gene lead to the disease or not? But as Professor Beat-Ritz explained, that's not necessarily the most important thing at this point. For anybody who's post-diagnosis, I think we're much more interested in the variables that determine whether or not the disease progresses slower or faster. Another fundamental problem is that there's just a lack of collaboration in the field. There's this siloed mentality. I've been to, at this point, well over probably 50 different research labs on my journey. I've interviewed over 80 different experts at this point, and I've gotten to know hundreds more. And I see very kind of clearly now that each person is working on pushing forward whatever little field that they're working on. But there's very few people actually stepping back and trying to take in the broader picture and see how all the different pieces connect with one another. And just another quote that I think sums that up pretty well is from Heidi McBride. Now, a very good visual illustration of another kind of problem that I see, and sorry if this kind of gets tedious like a list of complaints, but it'll get to a point eventually, comes from Alberto Espe, and I think this is just a good visual depiction of the simple, or a relatively simple problem, in that we still treat these diseases as if they're one kind of thing, and where in reality it seems that they're more of a spectrum of disorder. This became very apparent to me 2 weeks ago when I went to Japan to take part in the World Parkinson's Congress. There was about 1,000 patients in attendance, and just walking the halls, I did kind of a little mental experiment, just trying to compare all of the patients that I saw with one another, and trying to see how many kind of strands of this disease were really out there. And what was striking to me is among those thousands of patients, it was very difficult to find any two that presented the same set of symptoms. It was just a clear kind of visual demonstration of the fact that we're probably dealing with a spectrum of disorder. But, and this is where I'd like you to chime in if you can, there is points to be made counter to this. Can anybody try and tell me, why do you think this might not necessarily be true? Why do you think PD might actually be one disease that we might be able to target, or at least target most of the people that have it, with one kind of therapeutic approach?
The cross-section of people you saw at the Congress, they're all at different stages in the disease. So their symptoms would be manifesting at different points and at different rates.
Okay, yeah, that's very good. That could very well be true, that it's simply, rather than being on the spectrum of disease, they're just on the spectrum of the timeline of the disease. Anything else in particular? Yeah.
There could always be one point mutation, let's say, but the background of the epigenetics, other exomes, for example, can modify how that disease, or how that one single change might manifest. So that's one possibility about how there can be one, I guess, cause, hypothetically, in treatment, but the spectrum might result from their background, epigenetics, genetics.
Yeah, so there could be common kind of fundamental biological malformalities that ultimately that lead to a spectrum of disorder but have a common biological root. There's two other kinds of points that should be raised that kind of counter this whole argument. One are these drugs that we take. I mean, almost everybody who has Parkinson's is on the same drug, levodopa, and it works pretty well across the spectrum. Another example comes from some recent work done out of Scotland in particular. Has anybody heard the story about the woman who can smell Parkinson's?
Yeah.
Let's know.
So I don't know if you know the details of that story as well, but it's pretty remarkable. I think that in total, I think about 2015, there was a kind of a patient conference being held in Edinburgh, and this one woman kind of put up her hand at the background and said, "I can smell Parkinson's." Now, to the researchers' credit, they took her seriously, and they actually tested this. And I think they, in total, had 12 subjects, so 6 people with Parkinson's, 6 healthy controls. And they got an article of clothing, I think a T-shirt from each one of them, gave them to the woman and asked her to differentiate between the people with Parkinson's and the people without. She got 11 out of 12 correct, and the one she got wrong went on to develop Parkinson's 6 months later, or was diagnosed 6 months later with Parkinson's. So, and now this story is actually extending now. There's dogs being trained in Seattle that I know of that are being trained to also smell Parkinson's, and they claim to have a 94% success rate. So there does seem to be some common feature to people with Parkinson's. Now there's all sorts of things that could be confusing those results, and there's all sorts of caveats that need to be put in place as well. But there might be something common underlying there that we can tackle. But like I said, at this point, it's kind of still an incomplete picture. The next complaint that I have is science itself and the kind of fundamental drivers that motivate a lot of research. The reason why a lot of research gets done. Frankly, it's not always aligned with what's in the best interest of patients. And I sympathize a lot with researchers doing this work. One, it's a very difficult problem to solve. Two, there are all sorts of constraints on the profession that make it difficult for people to pursue their curiosities or to do things for the quote-unquote right reasons. But I've noticed, and this is a little bit hyperbolic, but there's a lot of sad truth to it. There's a comic that I found that I think really sums up a lot of the problems in how basic science gets done these days. Are most of you MDs, or does anyone here PhD as well?
They call it PhD slept in.
Okay. Well, anyways, I think a lot of you are familiar with these problems as well. They do seem to be pretty pervasive throughout medical science. Next, another kind of easy problem to identify is just how long drug development takes. It's basically a 12 to 18-year process, and figuring out new ways to actually make it move a little bit faster has long been a challenge, although there are some new things coming along that I'll get into a little bit later that are starting to speed this up. But this is just another kind of impediment to how we do things. In addition to that, it's not just about how we develop the drugs, but how we test the drugs. And to be very frank, clinical trials are not necessarily the best way to test whether or not a hypothesis is working. Now, these are kind of the 6 areas that a friend of mine has helped me identify as being the most in need of reform if we're going to actually properly conduct a trial. But just to sum up some of the sentiment, here's another quote from Professor Timothy Greenemeyer. Now, if anybody wants, I'm happy to go into the details of any one of those 6 things, but for now, I'll just kind of move forward for the sake of time here. So, as a result of all of these problems, here's what we've been left with. As far as I know, this represents about $25 billion worth of investment in disease-modifying drugs for Parkinson's that have all failed. We're actually up to 19 now because these two, isradipine and inosine on the top right, have been added to the graveyard lately. I think all of the kind of complaints that I presented before are integral reasons for why we've had nothing but failure essentially so far. Now, the good news here is that people are starting, I think, to learn from the mistakes of the past. So the next big trial, I think, that's going to be starting soon is with this drug called exenatide. And they're starting to apply some of the lessons learned, and in particular, they're trying to identify, and I think the critical problem here is identifying which patient from the Parkinson's population would be best suited for that drug. I think a lot of these drugs had some benefit in some people with Parkinson's, but identifying who that subgroup is has been a giant challenge so far. And I think going forward, until we can molecularly subtype patients, it might be a good idea to stop these trials altogether, because more likely than not, we're just going to have a continued list of failures. Another thing, I won't get into the solutions quite yet. Meanwhile, this problem is becoming a pandemic of sorts. The number of people diagnosed with Parkinson's is growing pretty rapidly. And patients, frankly, don't have access to the kind of care they need to properly deal with this disease. And this is just a good illustration of the lack of access to care that I think patients experience. I mean, I get about 30 minutes every 6 months with my neurologist, which just frankly is not enough time to understand all of the things that go into this disease and how to actually properly treat it. I mean, if I wanted to just focus on properly managing my symptoms, it's almost a full-time job. I have to be very mindful of how much sleep I'm getting, the food I'm eating, how much water I'm drinking. I definitely wouldn't be doing presentations because those are terrible for your symptoms as well. There's a long list of variables that go into determining how my symptoms actually manifest on any given day or at any given moment. So like I said, all of this leaves kind of an inconvenient truth. The pace of therapeutic development is bogged down by a system that cannot keep up with our degeneration. So the question is then, what do we do about this? How can we actually push things forward? How can we move forward? And before I go into what I think should be done, I want to just give you guys a minute or so to think for yourselves of, a minute might not be quite enough time to think of solutions to these problems, but if there was anything in particular that came about, or any thought bubble that was provoked as I went through my list of complaints. I'd love to hear about it. If anyone has any, would be hazard to say what they think how to solve some of these kind of systemic problems.
I don't know if Parkinson's disease has the same type of group as the Alzheimer's disease, but as you mentioned, it's all very siloed research. I believe the Alzheimer's group in Canada now has a consortium of multiple specialists all over the country, and North America actually put together their research, and they're all tasked with specific kind of parts of the puzzle to put it together. So maybe developing some sort of group like that to help a more collaborative approach to figuring out a solution for Andrew.
Okay, yeah, the more kind of broad consortiums, I think, the better. Going back to my other question that I asked at the beginning, are most of these problems unique to Parkinson's, or do most of them actually go across disease boundaries?
This is very general.
Yeah.
I mean, it's a great summary, but I can think of, in fact, there isn't really a disease in neurology I can think of that where these issues are not common.
Mm-hmm.
So
Which
why is that? Why are all these the same?
Well,
You've pointed out a lot of the issues, the complexity of the diseases that we deal with, the variability on a population level from patient to patient, the lack of funding, and the fact that a lot of our research, if not most of it, is not patient-driven. It is driven by many other factors and patient-related outcomes, which is what we now like to label them as, patient-driven sort of, or patient outcome-related research. Has not been foremost in the field for many years, up until very recently.
I think you had.
One idea, funding, the way it works now, you apply for a project, a proposal as a single unit or group of people working together, but perhaps funding agencies like the NIH, CIHR should be actively looking for these collaborative opportunities and funding rather than a group of scientists at one institution, but funding a group of scientists across many institutions for a single project to collaborate on. I know it's just an idea that, I don't know if that exists, but maybe an early solution or an early idea that could counter some of the problems.
Okay. Yeah, I think that could be very helpful.
And also a means of actually communicating patient priorities and patient issues to the scientists that are actually working on projects. I don't think there's anything that actually allows us to identify those, except for people in individual institutes, clinician scientists perhaps that actually have a patient population who they can hear from, but there's no general system which actually drives it. So like you said, again, if that kind of encourages that silo effect where people just study what they think is important as opposed to one uniform database where you can rely on what a whole bunch of patients identify as important things that need to be worked on.
Yeah, I mean, I agree completely. Yeah.
The other idea is public data. So like ADNI and Alzheimer's disease is publicly accessible to the whole world. Andri in Ontario will be. So creating a mandate that data becomes public, it allows for easier collaboration too. But of course, there's ethical concerns with that as well. But that's one innovation in our lifetime that is becoming a bit more prevalent. Like 10, 15 years ago, I don't know if that was necessarily the case, but now these public repertoires of data are becoming more prominent, and that might promote better collaboration.
But also, and it's probably sad to say, but part of the reason why there is not a whole lot of collaboration in the field of sciences is the risk for funding publications and wanting to be the first and wanting to think about your next funding proposal and your next research project and trying to keep everything sort of tightly secretive until it's published. It's you need to survive in the field, and that is one way of doing it. And so I think in order to encourage more collaboration, there has to be an incentive above and beyond, of course, the desire for public good, which of course we should all have. But there has to be an incentive for us to sit together and to collaborate, which at the moment, unfortunately, is difficult given the challenges within the field.
Yeah, I mean, I agree completely with everything that was said here, and a lot of the solutions that I'll propose were just spoiled in some ways. But it does seem like the kind of model that science is built on was built on almost the Albert Einstein model, where this one singular genius is going to come along and solve all of our problems for us. And I think what we're learning, especially in medicine, in particular is that these problems are too complex for any one person to actually come up with any light bulb solutions by themselves. It's going to require these broad collaborative efforts.
So Ben,
Yeah.
if most complex systems, any type that we know in the world, don't work by pulling one lever and everything else just falls together, that there's multiple things going on, why would we think that we're going to pull one lever in this thing?
Well, I guess that's just kind of the backbone of science in some sense. Like Albert Einstein, I think, ruined us, or set people like the Einsteins of the world. Although that, I don't know. I think that's just how science has been born and bred in the society that we live in today. And also, I think fundamentally, for a lot of these issues, and this is not something that I address as well, but fundamentally, a lot of these issues comes down to the driving forces that motivate society in general. I mean, we've decided as a society that the ultimate kind of carrot at the end of the road is money. And that the way it gets distributed, we look for jackpots in a sense. I mean, we have almost a jackpot mentality to how we incentivize people to do work. And that fundamentally might be something that we need to reconsider at some point, although that might involve actually restructuring how all of society works. I hope we don't have to kind of change capitalism in general just to fix medicine, but that might actually be what we have to do at the end of the day. So, like I said, are some of the things that I think need to be done. And frankly, I think Canada has a unique opportunity to play a central role in fixing some of these problems. So, like I said, I've traveled pretty broadly. I've gotten a chance to assess different healthcare systems and different research systems as well. And I think I can confidently say that Canada is primed to lead the world in many of these things and to really spearhead a lot of these changes that I think we need. And these are kind of the 6 pillars, in a sense, of what I think need to be done. And I'll elaborate a little bit more on each one of them as I go forward. But these are the 6 things that I would point to as saying need to happen if we are going to actually make the kind of progress that we want. So the first one, this is actually a little bit of shameless self-promotion as well. I'm working on a book right now with a professor who was trained here in Toronto. His name is Alberto Espe. I actually just spent the last 2 days with him in Cincinnati, where he runs the movement disorder clinic there. And together, I think we're trying to kind of coax the field into a new way of thinking about these diseases, and trying to break down some of the barriers that exist between them, and trying to think of new ways to actually push things forward. And I'm not going to spoil everything, but there are 2 quotes that I think really sum up what we're trying to do here. So the first is from someone who has kind of an ominous ominous legacy to himself, but I think what he said there is very much true. We need to think of nature and biology very differently from, I think, the way that we looked at it in the past. We have this sense that the world works in kind of a sequential manner, and that one thing leads to another thing, leads to another thing, leads to another thing. But I think what we're learning from physics in particular, and I think these lessons are going to one day be applied to biology, is that that's not necessarily how nature itself works. Nature is not a sequential set of cause and effects. It's rather these giant holistic systems that all kind of bounce and bleed into one another, and trying to make sense of it by, identifying a pathway and saying, oh, this enzyme then catalyzes this reaction, and this reaction, and this reaction, might not necessarily be the best way forward. And then another quote that is central to the book is from John F. Kennedy. I think that there's a lot of myths that have been built up in medicine. And they stem from the language that we've chosen to use to describe these diseases. Words like Parkinson's and Alzheimer's, I think these days are almost doing more harm than good. I don't think there is anything in the natural world that we can identify as Parkinson's disease. There's nothing we can point to and say, that is Parkinson's. I think we need to kind of, in some sense, have some sort of collective brainwashing and get rid of some of these labels that we've used and think about if we didn't have any of these labels, how would we re-examine these diseases from the ground up? How would we actually try to identify what it is that we're dealing with from scratch, so to say? So the next pillar is a movement of science for society. And like I said, I think Canada can play a leading role in spreading this throughout the world. And there are four kind of aspects of this, but the one I want to focus on is the open science movement, which was alluded to over here. I've come to, I think, believe fundamentally that open science is in the best interest of patients and society by extension. And there's some arguments both for and against that we can go into as well, but it does seem to be a growing movement as well. There seems to be more and more institutions taking on these policies on an institution-wide level. One in particular is in Montreal, at the Montreal Neurological Institute, where they have a policy now of open science that they've mandated across the neurodegenerative diseases, across the brain diseases that they deal with. They've actually taken a much more radical step as well, in that they're doing away with intellectual property protection, at least on the basic sciences and in the preclinical work that they're doing. But again, to try to play devil's advocate for a little bit, can anybody try and tell me why they think open science might be a bad idea? Why might open science actually impede progress? No one can think of any? Must be a good idea then. Well, I can think of some. And it comes back to what we just talked about, and that is what incentivizes people to do their best work. History, at least recent history, tells us that people are motivated by selfish interests. We put a jackpot at the end of the road, we make them chase it, and that's kind of it's what's led to all of the innovation that we see in society today. It's why we have these projectors and these computers and all of the things that we have in society are in some sense come from that kind of primal incentivizing structure that's in place in society to make everybody chase the golden pot at the end of the rainbow. Open science in some ways would do away with that and make it more of a collective pursuit. And when you put when you incentivize people for collective interests, they might not wake up as motivated to go and do their best work, because it depends how you look at human beings, but a lot of people would say fundamentally we're selfish creatures that are driven by our own self-interested natures. Now, you can debate how true that is or not, but that does seem to be that does seem to be a stumbling block. And frankly, I don't know what the answer is there. Maybe we do our best work, at least maybe not as individuals, but as a society, when we try to incentivize each person to go for that jackpot at the end of the rainbow. The next thing that I think fundamentally we're going to need is a different approach to drug development than what we have had so far. In particular, how we take our preclinical targets and translate them to the clinic. Now, there's one group in the Parkinson's field that I think is really spearheading a new way of how to do this. It's a group called the Silverstein Foundation, started by a man named Jonathan Silverstein, who himself was diagnosed with Parkinson's not too long ago. So he kind of rallied all of his resources together and started this foundation. And they had a target that they went after pretty recently. And in just 19 months, they went from an idea to IPO and IND approval. Now that's pretty unheard of in the field. It's a gene therapy technique that they're championing from a company called Prevail Therapeutics. But I think the model that they've undertaken is one that I think a lot of disease areas could learn from. Also, what they've kind of understood is that they're not trying to treat Parkinson's in general. They're just going after the GBA-related form of Parkinson's. So that's a genetic form, which I happen to have as well. I think it comes from an understanding that we're going to have to tackle this disease 1% to 2% of the population at a time. I think any cures that come about are only going to be curative for a small fraction of the people that have any one of these diseases. Next, another thing that I think is going to be needed are these. Okay. Comprehensive neurotherapy centers. There's a lot of talk today about integrative medicine and holistic care, but little action actually being taken to push these things forward. Frankly, there's a bet that I'm thinking about making, and I'm trying to think about how to actually announce this bet or how to actually make it to the pharmaceutical industry, which would say that all the billions of dollars that are being spent on drug development these days, we would be able to do more good collectively if we invested that money in a network of neurotherapy centers. I think that these would ultimately do more to slow the progression of these diseases than most of the drugs that we have in development. Now, again, anybody want to take a stab at why this might not be the best approach to take? Why these kinds of neurotherapy centers might not be the best place to put our investments?
Might be a bit challenging to actually implement, to figure out exactly what type of exercise, for example, to actually have these centers that we think would be beneficial.
Yeah.
I guess we don't have a starting point.
So a lot of the sort of non-medical approaches to neurodegenerative disorders, I mean, some of them do have some evidence base, but a lot of them don't have very strong evidence base. So it would be difficult to pick out the ones that are truly evidence-based to implement along with the therapies that have a lot of clinical trials.
I'm a full proponent of all of these things, and they're crucial, but focusing all of our money on only these things is a bit of a shotgun approach, and also moves away from a targeted molecular approach. That could be one argument against this.
Yeah, I agree. Again, I agree with basically everything that was said. There's another kind of factor that I found that might be impeding this as well. So in Cincinnati, where I just came from, they actually have one of the best kind of comprehensive clinical care systems that I've seen so far. They have a whole floor of their clinic is just dedicated to physiotherapy, and they have all the latest equipment and some of the coolest gadgets to help physiotherapists treat their patients. They also have like yoga studios and acupuncturists and all sorts of other things available for patients. But there's a kind of key cog in how medicine is delivered that is kind of a difficult, I don't know, I need to be very careful how I say this, but I guess it ultimately comes down to who makes the decisions for the patients. Is it the physiotherapist? Is it the acupuncturist? Often that is not the case. It is the neurologist. The neurologist makes the kind of quote-unquote most important decisions for how a patient gets cared for. But while there's a lot of kind of sound fundamental basis for why that is, a lot of neurologists are not trained to take this kind of holistic approach to the treatment of patients. It's certainly not how, I mean, you can correct me if I'm wrong, but it's certainly not how you guys are being trained. I mean, you're kind of trained to assess the patient in front of you and see what kind of, for the most part, what kind of medications you can give them to help treat them. You're not necessarily going to be there prescribing exercise or a change in their nutrition or lifestyle habits. A lot of that is because you don't have the time for it, and there's constraints, and they don't have access to those facilities. But just having that central decision maker be the neurologist is something that I think we might need to think about how to re-examine as we go forward. Next is, like I was alluding to time and time again, is breaking down these boundaries between these disease areas. So I've started to become part of a campaign called Cures for All that's trying to do away with these boundaries, and essentially the underlying premise is that a lot of the advances in biology that have happened in the past have had broad spectrum applications. I mean, iPS cell technology, organoid development, chaperone molecules, all of these things are not disease specific. I think almost all of the big advances we've had have not been disease specific, and yet we still have these tightly defined diseases that we segment our population into. While that makes sense, I think, clinically, I don't think it makes sense very much on the basic science level, at least to some degree anyways. what I'd love to see at some point is that research labs in particular stop calling themselves a Parkinson's research lab or an Alzheimer's research lab and kind of have better parameters by which they define themselves, or at least define themselves a little bit more agnostically. Finally, the last kind of stumbling block that I think needs to be overcome is just connecting the world a little bit better. Like I said, I've traveled all around, I've seen different healthcare systems, and I've noticed very strikingly that there are parts of the world that need more help than others. Canada is in a pretty good position in terms of if you look at the global spectrum. There are a few places in the world I'd rather be a patient than in Canada. Now, there are some places where I would rather be a patient, but Canada is definitely close to the top of that list. There's one place in particular that I've gotten to know pretty well over the last decade or so, and that's here in China. So estimates have it that over the next 10 to 20 years, more than half of the world's people living with Parkinson's will all be in China. I've been to some of the clinics there. I've seen what it's like to be a patient there to some degree. There's one clinic in particular that I went to in Shanghai where there's this famous doctor there. He had a lineup outside of his door of about 50 patients deep, and he had about 20 to 30 seconds to diagnose and prescribe a medication for each patient. I think, and here's a little cheesy graphic to illustrate that, more needs to be done to try to bridge these disparate communities. And I think that bridge should be built on education more than anything else. For me, education has been the kind of backbone of everything that I've done. And I think fundamentally going forward, it's going to be the bridge to connecting the world together. There's a dearth of information available in Chinese, but not just in Chinese, in Spanish and almost every language in the world, even in English as well. Although English definitely has access to more information than almost any other language. I think I've just seen from some of the little efforts that I've put out to try to produce a little bit more Chinese language content, that it has a pretty grand effect. And you can really galvanize a whole community of people if you just take the little steps needed to reach out to them and make things accessible in a language that they frankly understand. And with that, I'll say thank you. Oh, I have to go over this slide. I'll let that speak for itself. And with that, I'll say thank you for taking the time to listen to me today. And I mean, I'm open. I have the next hour essentially if anybody wants to ask me any questions or if anyone has any comments they want to make. But also feel free to reach out through any of these channels if you want afterwards, if there's something that you want to say or something that you want to connect about.
And the evaluations that you'll get in 5 minutes. So.
And like I said, in particular, if you have anything that you want to say about how these problems that I've alluded to correlate to other disease areas, I'd love to hear about that. So yeah, if there are no questions, then I'll say...
I have one.
Okay.
We got a whole bunch of young MDs in here, right? So what do you see as if you had $1 billion based on everything you know right now, where would you spend it? And you only get to spend it on one thing.
I'd probably say spending it on early identification of these diseases because, in neurology, we're all too late. We're picking up at the clinical stage or the MRI showing abnormalities, but, the preclinical state is where, a lot of these therapies are unknown or the chance to modify, the brain before damage happens. So trying to pick up, we can't just take a piece of somebody's brain when we think they're having symptoms or when they're born or whatever. So we have to find other means. So I think finding those means, CSF, biomarkers, whatnot.
Anybody else?
I think understanding the patient. We don't really have time in our environment to spend time with patients, actually understand their disease, be able to characterize them as well as we can. And as you mentioned, a lot of the problem with these diseases is they're very heterogeneous in how they're presenting. We don't know what subgroups will respond to what types of therapy. But a lot of that time is because we don't have the time available to us to understand exactly the patient's diseases from a time with the patient perspective, just because of the way the shortage of doctors. So I don't know if there should be an effort put into resources available to prolong our time with patients and our exposure to patients to better understand what they're actually dealing with. Seeing if there's some clue that could help identify certain styles of patients that we can target.
Yeah, on that note, actually one thing I'd love to see is more of this as well. More patient research or patient-doctor exchange programs. I've learned a lot just interacting with doctors, and I think I've been able to teach some of the doctors things along the way as well. I think if there are just more formalized systems in place for these exchanges to happen, it would not only benefit you guys and help you guys do your work a little bit better, it would help the patient as well educate themselves and also, in some level, empathize with what you guys are doing. I mean, there's a lot of frustration that's built up in the patient community around a kind of misinformation about what doctors do and what motivates doctors to do their work. And some of that frustration can build up at times, and I see it all the time across patient message boards about some of their skepticism they have about the way the industry works and the way the profession works. But I think if there's more of that kind of cross-cultural bridges developed, it would help to address some of those problems. Yeah.
I think with $1 billion, in addition to the methods already mentioned, I think from a basic science standpoint, when we look at all of these neurodegenerative conditions, and I'll loop in prion disorders too, it's a problem of an abnormal protein that self-propagates and spreads. And we know from the Alzheimer's literature that targeted antibodies against amyloid beta have pretty much failed to date. And so I'd invest $1 billion in understanding how do these proteins spread rather than targeting just one specific type of protein. So understanding that process may actually help with #CureForAll type of approach, where we're unifying all of these conditions and looking at the process of how these abnormal proteins spread.
Yeah.
I have another question.
Go ahead, Hugh.
How do you, as young docs, feel about going into a field called neurodegenerative disease, where the prognosis is that way for the most part? It's always that way.
Yeah, actually, that is something that I empathize with you guys a lot about. I mean, as well. Parkinson's in particular is probably one of the best diseases to have in those clusters of neurodegenerative disorders because there is things that you can do for your patients. I can't even imagine what it's like to see patient after patient for which there's almost, I don't want to say nothing you can do for them, but there's very little tools that you have in your toolbox to actually help them.
I think what is motivating is the hope and the promise of contributing to discovery. I think for myself anyway, that's a motivator. Sad to not be able to offer right now curative therapies, but I think the field requires minds that are interested in discovery and interested in innovation. So that's, I think, one driver that may push many to this type of field, despite the prognoses not being as good as other neurological conditions.
But it's a special group of people here, right? I mean,
Yeah, no kidding.
the notion of neurology that all other specialties will tend to say is, or at least in the past, was diagnose and adios, right? It's
Yeah.
neurology. And neurology is changing, and it's different when I was sitting in these seats during these kind of talks. And so I think it's a group of people who are pretty motivated to see change, and that's one of the reasons they went into neurology.
And on the top of that as well, another kind of question that I have is, do you think the kind of changes that we are talking about here, is it more likely that they're going to come from within the field, or is it going to require external forces kind of acting upon? Because something I've been thinking about doing with my own kind of advocacy is starting to become a little more political about it, because I mean, I've gotten quite a few quotes from people saying the changes are not going to come from within, or at least they'll be accelerated if there's more outside pressure, or even better than outside pressure, just more outside funding for some of the broader spectrum things that we need.
And I agree with you, the changes are not going to come from within. Like, our hands are tied. If there are medications, for example, that are available in other countries that Canada A, hasn't approved, or B, doesn't have funding. We do run, we have these problems almost on a daily basis. Oh, drug so-and-so, we need compassionate funding for it because it's not funded in Canada, and then you have to go through a process of applying for funding for months or years at a time. So it's not, the will from within the field is great, and of course we come into the field with hope that, yes, there are frontiers where we can contribute to, much more so in neurology than any other field in medicine, but we are limited very much so by systemic issues that we cannot change on our own from within the field. There has to be a political will to change, there has to be a scientific will to change, and money is always an issue.
I also think you need to be a rule breaker. Just all those myths that you were talking about how science is done a certain way. A lot of the time, people do fall into that trap of doing the same thing over and over again, and not actually breaking out of it and discovering new things. But part of even the open science movement, like starting that whole open access program and sharing research journals, that someone started it. Someone just decided, let me just collaborate with other people and figure this out and start a program, and that's how it happened. So I think people just need to be more brave and break a rule every once in a while.
Well said, and if any of you need any help breaking any of those rules, feel free to reach out. Okay, I think the hour is up. Like I said, feel free to shoot out any questions you have through any of the channels that I brought up before. And I have time now if anybody has any one-on-one questions that they'd like to ask as well.
Thanks so much for coming back.
Thank you for having me.
Could I make one little pitch before we go?
Sure.
You may not be aware of this, but you are at ground zero of one of the leading hospitals and research hospitals in the world in Parkinson's research.